Today I'm going to try and give almost a perspective on something that I think is an important health ecosystem that folks, many here, many at Rice and elsewhere, have been talking about for a while, and now is at this really interesting inflection point. So this idea of the living or implantable pharmacy and how that provides an intersectional way for all of us across AI, bioengineering, cell engineering, clinical sides to connect on something that could really be a bridge in terms of caregiving for so many folks. So we'll get into that, just a little preview. Very good. So that's kind of one of the goals, is describe this design space of what we would call pharmacotherapy devices or implantable pharmacy or the living pharmacy. It sounds a little science fiction based, but could be really interesting. We're going to talk about some of the challenges of building these things. So this is integrating large teams of 10 to 20 different labs, 50 to 100 trainees, many clinicians, going through FDA process, all of that. We're not going to jump into that side of it necessarily, but also talk about how these devices bring up some really, one person might say interesting, another might say terrifying. Okay. The other side of this is these devices really make us think maybe twice about the intimacy of care when it's inside of us, when we have some notion of control, but also we may not necessarily have complete autonomy over these devices, or do we? And so that's kind of something we're going to jump into, and I hope we will invite comment and thoughts and questions from the audience as we think about this, because I feel like these devices are really coming to the forefront of care, riding that wave after biologics like Ozempic and other things. Okay. Oh, wrong way. Before that, I just want to give you a little bit of context so you know where I'm coming from. So I know there's a fairly diverse set of folks in the audience. My background is as a device builder, and then moving into behavioral sensing and passive analytics, and now into interventions. So we've all had kind of interesting stories of how we got here. But my lab is called Kamo Omoa. We're a team of about 40 folks. Name is inspired by my Native Hawaiian heritage. And that also kind of inspires a lot of the ways that I think about health and sustainability, because I think those are very interlinked, especially coming from, an island kingdom. So this is the lab. My nose looks really big on this, so just ignore that. Here, I'll hold this over here. No, it's selfies. This is some of the lab out at Georgia Tech. I just wanted to recognize that really these are the trainees, the staff, the research scientists, the postdocs that are doing so much of the work, and then I get to stand up here, luckily, and talk about how awesome they are. And so I'll try to do that justice with them. So quickly, some kind of guiding principles, and I hope that while these are general to us at the lab, also permeate a lot of the space that we're going to talk about, and also that all of you, within this artificial intelligence, data science, analytics realm, also recognize, because we as technologists and clinicians translating a lot of this technology into patients' hand have a lot of power and responsibility. I'm not going to say the Spider-Man quote, but you probably heard it anyway. And I think these types of tenets are really useful just as we think about the next part of this really decade of AI influencing both the policy and implementation and the operations of care across all of health. So sustainability is one of these principles. You can see a couple different ideas of how this might look. This is biodegradable robots, face masks that are powered from your breath, and then give you interesting maybe markers of your health. Cyber infrastructure that can be deployed outside to monitor ecosystems and then help tribal nations make decisions on water and quality and things like that. This type of our work lets us get to fun places. So this is the Hawaii Institute of Marine Biology, where we got to deploy some sensors with some students on a protected reef that they are restoring. So health of people, health of reefs, I think are actually interconnected. This is one of my students, Eric, out deploying water quality sensors with Ojibwe tribes in the Midwest, in Wisconsin. So beyond sustainable, we also think of a guiding principle of responsibility. And so that's actually part of the name of the new center at Georgia Tech that's looking at how we approach these computing technologies and where they sit, both in their actual design from the materials up to the implementation and the human interaction. Right? So this is really broad. And maybe people have already talked too much about responsible, accountable AI and things like that, but two instantiations I think of, at least in this case, to give maybe more context, is the idea of privacy. So how can we make things that are privacy preserving? Obviously we have federal regulations that influence how we might think of that, but we can also address things like stigma. So how can I learn the behaviors of a person by attaching a camera to their neck, but respect their privacy? Those things seem in conflict, but we'll talk about that. Another one in terms of responsibility is how we design the devices themselves. So one of my students has led actually, is actually submitting a paper on this tomorrow, getting frantic texts, on how we design or co-design wearable devices with low-income or historically marginalized communities. For example, Latinx communities in Chicago and LA, which is where our study came out of. And so involving communities that maybe didn't have as much say in the initiation of a lot of this technology, and let's be real, a lot of this technology comes from one place in California and is designed originally with the needs of that particular population in mind versus other populations. And so as we think about how these technologies and things that we're building are brought to bear, maybe they need to be inclusive of these folks that often face more challenges in terms of gaining care. Finally, we're also thinking about accessibility. And so I think of this a little bit differently from the responsible aspect, because this is very, almost a practical concern of if I have to, if I live on one side of Texas and I have to drive all the way to MD Anderson Cancer Center and I have to receive a treatment, multiple times in a month, that's really hard if you have multiple jobs, work late shifts, have kids and can't get childcare. So a part of the actual impetus for this living pharmacy idea is how do we get cancer care outside of the clinic? And really all these other types of things, like from wearable heart monitoring to other types of interventional tools, can we move those outside the clinic and automate them in some way so that we can reduce the burden on both the patient and the caregiver? So in that sense, you've seen a bunch of kind of fun pictures of things that the lab has done that we've built over the years. My expertise was originally in computer systems, then devices, and then has moved actually through each of these places. Our approach now is to think about how we can integrate across these 4 different areas. So materials and devices, if we have a new material that offers some really interesting property, maybe we can wrap it into a computer system of some type. This could be an autonomous system, an agent-based system. This could be something you hold in your hand or something a little more invisible. Can we apply these signal processing, statistics, machine learning, interactive AI, especially human-centered and human-focused AI technologies to mediate how we use that system in the real world, and all in this context of very much within the way that humans interact with technology itself, so human-computer interaction. All right, so that's kind of some of the things of the lab, and that's those grounding tenets that I hope will kind of guide maybe some of our discussion and questions and comments and how we think, maybe about hopefully the whole day and about this technology going forward, but also at least this talk. So here's the things again. Let's jump right into kind of what we're going to talk about by first giving maybe one more, here's the sad statistics slide on health, the state of health that I know is probably trite for many of you, but I want us to try and think about it from this personal perspective that we've already talked about a little in the talk. So the problems of disease burden with chronic diseases like obesity, diabetes, that impact on health, that impact on the cost of healthcare delivery. These are some of the things that shape why we're all here, right? And I think we also have this, it was great to have folks from MD Anderson up here talking about the Operations Center on Cancer. Like the burden of cancer on our health system, but also on families, communities, everything is just really, really challenging and hard to ignore. And this is a lot of the thing that we're trying to overcome or think about how we might overcome with technology. So something that also informs this accessibility notion is, well, the cost of care. So something, like, I think, yeah, I picked Ozempic for this because that was the GLP-1 agonist were the 2023 Science Breakthrough of the Year, right? So I don't know if you caught the cover, with the injector with the little fork. I should have thrown that up here. Those have changed, right? Completely changed maybe how we think about or approach diabetes and weight loss. But it's also completely changed the capacity for us to deliver that type of care to those that need it most. Same is true, and probably really has been true for a long time, for the cost of care of various cancer treatments. And I'm focusing on diabetes, obesity, and cancer for a reason. We'll kind of get to that as some of the motivating, let's call them clinical translational applications for this idea of a living pharmacy. And another set of factors is every person has a unique healthcare trajectory. So the title of this talk includes the word personalized, right? It could maybe also be precision, but I liked personalized so that we really think about individual who is hosting this device. But there's some realities of care that combine that make treatment not really available for everyone, right? So we're probably familiar with distance, right? We talked about that, how if I'm on one side of the state and I need care from a certain place and I have other things that I have to do in my life, as one does, that could be a challenge. Environment, so we still do, talk about food environment, right? So adherence of things like Ozempic, once you stop taking it, depending on the food environment you're in, that will maybe negate all the progress you might have made for something like weight loss, right? So those are realities that are sometimes not changeable for an individual and basically take that person out of the marketplace of care. Well, also, of course, adherence. So a lot of the interesting, most powerful biologic-based therapies, right, are injection-based. And some of the really most powerful are multiple injections with different regimens. So we've had adherence problems for things like statins, which have been around for a long time. How much worse does it get when there's a challenging or different injector at a different time for these new types of drugs? So adherence is always a problem. Type adherence, obviously, into PubMed or Google Scholar. You've all done this, and it's just whoosh, huge. And this, of course, informs how we might design an agent or a piece of technology or a device that could sit in a healthcare gap. All right. Now, that was a little bit depressing. Welcome to the morning, Wednesday, woohoo. But I want to talk about kind of now, I think we're at this really exciting inflection point in healthcare generally. Even just the things that folks are talking about today, not just like these advancements in analysis and artificial intelligence, these different ways that agents can be used. I mean, we have large language models now, which are both a little bit terrifying and have a lot of weird things happening with them, but also very exciting as potential mediators for kind of care and how we understand it. Deep learning and machine vision and all these other things like miniaturization of compute, all of it's kind of colliding right now in ways that are bringing about just crazy possibilities for what the future of health and really society might be. So let's dig into that a little bit. Oh. Sorry about that. So when I say this infrastructure of AI, this infrastructure of computing, miniaturization of compute, and then years and years of work on biologic, different types of cell therapies. All of this kind of has come to a head where we're asking this question now, can patients make their own medicine, right? So you have, an injectable biologic, right? You keep it in the fridge, Ozempic. Maybe you or family members or others have dealt with these types of drugs before. You might forget about them on a plane, and you go travel. Oops, you missed a dose. How's it going to impact you? You start it the first time, and it's such a high dose that you're kind of slowly trying to kind of get it right. But then you have really not very fun gastric side effects, and then you drop off. But can we turn a lot of those challenges that I mentioned, the harsh realities of care, on their head by having patients make their own medicine? So what does that mean? So In this instantiation, right, so I'm going to talk a little bit about devices. Maybe this is not as many device talks over the conference, but let's think about this kind of ecosystem. First, you have some type of subcutaneous implant, so under the skin, or maybe in a bodily cavity, right? Not as invasive as something like a pacemaker or some other deep device. This is something that in a perfect world, right, would be syringe injectable, or done with a very small cut under the skin, similar to some of the continuous glucose monitors, like Senseonics. This would host engineered cell factories that would produce whatever that therapeutic might be. So this could be an immunotherapy that could fight or help train the immune system to fight cancer. This could be something that directly could be tirzepatide, dioxide, semaglutide, something like Ozempic or Wegovy or Mounjaro. Those are patented, so maybe not those necessarily, but let's think big. And this would sit inside you, and almost using your own resources of your body, as well as the electronics, maybe think of it as another organ, would generate these therapies to treat that condition. So that's pretty wild, right? When I first heard about this, I was like, what the heck is this? That's very interesting. So let's complete the ecosystem, though. Now, this is inside of you. How do you understand it? How do you provide precision dosing and timing? How do you see if there's side effects or other things that are happening? So on the other side of this, we have wearable. And actually, this wearable could even be the abdomen band that you see right here, or it could also be the shoulder band, or it could be a watch, or whatever it might be. So there's some mechanism that is most likely interfacing and connecting with that implant, controlling it, but also, and this is where this bridges into the past decade of my work, connects to that wearable device as it's interpreting the things that you're doing as a patient. So are you eating? Are you sleeping? What's your circadian rhythm? What is your mental state? What's your heart rate? Right? Even things like that. Are you sleeping? All these different types of things that can then inform how we might deliver the implantable therapy itself. So in a sense, we are taking away some of those adherence problems, potentially, hopefully finally and precisely tuning the delivery of a needed therapy to your own dynamic situation. And of course, along within this ecosystem, we also have this phone, right? And so everyone has a phone in their pocket, and it's the culmination of a century of just exquisite engineering and miniaturization and trillions and trillions and trillions of dollars to achieve this piece of computational capability where you have a data center in your pocket. Like literally in your pocket, you turn off the Wi-Fi, you still have a significant capability to do things like edge computing. That's a really powerful resource for this ecosystem in crunching what might we want to do now that we have this closed loop control of a life-saving drug delivery. So this is in some sense also the maybe next step beyond auto injectors and other things like that, the artificial pancreas, right, where we're actually making our own medicine and hopefully staying with you for life, especially if it's a chronic disease. All right, so just a little bit, and also I'll call out some other investigators, right? So this is a very large project, this idea of living implantable pharmacy. The federal government has, luckily invested a fair amount of money into this over the years through DARPA and now ARPA-H. And there's many investigators actually here at Rice that are doing a lot of work on this. So this is, Omid Beza, who leads these cell-based therapies where he and his lab are making engineered cell lines that can deliver and create these cells in perpetuity. And the research goal, right, is how do I pack as much potency in as small a package as possible so that I can have as small an implant as possible, which increases adherence, reduces challenges with the implant control, and hopefully increases your quality of life. So potent cells, engineered cell factories with this cellular and synthetic biology. And even, honestly, within this space alone, coming up with these cell lines and automating how we might determine what cell lines are really powerful is an application of what we might call AI, or AI, because these are interpreting results to make decisions on the next line to kind of attack or focus on, because the possibilities are so unlimited. The other side of this, and this was I think published last year in Nature Communications with our team and folks at Carnegie Mellon, Tsai Cohen-Carney's group, and Jonathan Rivney at Northwestern, and folks here at Rice, Jake Robinson, Nomi Beza. This idea is, well, we have these cells, but we actually have to keep them alive, right? So we're put in some place, maybe there's not a lot of movement, of blood flow, of oxygen. Cells need oxygen and other nutrients to survive. They need water, all kinds of things. How do we build the life support system for these cells inside our own body? And this was actually to make a literal oxygenator that sits inside of your body and keeps these cells alive, as well as electrical stimulation, so circuitry that is kind of intelligently triggering the cells, giving them energy as they produce, or telling them to stop producing if maybe we detect something like, I don't know, toxicity or lack of efficacy, or maybe we just don't want to deliver a dose while they're eating, or if there's some activity about to be happening. The other side of this, we already talked a little bit about, right? The wearable itself. I want to sense the environment and the patient state, the behavior, and then mediate that control with the patient. This is also where we have the opportunity to conduct inference, we can charge the implantable, and we can communicate with the phone. And then we kind of get to this, I'll say, a little bit all-encompassing point where these pieces of computation or analytics or agent-based decision-making tools sits in the gap between these devices. So can I compile these different, very multimodal data sets, right? Everything from a health record to the clinical plan for treatment, to what the person has been doing. Are they sick? Are they reacting? Is something else happening? And to precisely tune maybe that dose or that control, or do other things with that data. All right, so as I mentioned, this kind of started, I'll give a little bit of a backstory, with what was called the DARPA Adapter program. And so this is when I was back at Northwestern. Jonathan Rivney was the PI on this. And the idea was to build this hybrid, kind of the example use case of the living pharmacy. And for this was focused on circadian rhythm entrainment, which turns out to be really hard, but we can get into that later. Everything's hard, right? So this is how it was kind of applied, where we would have the sensors estimate your rhythm state, where you were in your circadian rhythm phase. And this could be through an internal temperature sensor, so the implant itself would have sensors. It could also be other things like a melatonin-based sensor on the wearable, maybe even cortisol. We didn't get to cortisol, but we're looking at melatonin now with Shana Kelly's group. And this would be used to estimate where you are in your circadian rhythm. Now say you go into 6, 8, 12-hour shift of time zone because of travel. Now we need to figure out what that desired shift needs to be, and then we actuate, stimulate certain peptides, leptin, GLP-1, to entrain you faster to that new time zone. So this is an example, right? And we've now taken this into more of the ovarian cancer world. But this is kind of that original, okay, let's take a use case and figure out how some of these systems work together. Because in the end, you would also have this interaction with, sleep is very personal. So maybe it's like, well, no, I don't want to do this, adjust this. How do we mediate then the connection or control with the, at the time it was the warfighter, but with the patient? And who also has control of this? And how do they autonomously how do they want to deliver that therapy to adjust their body to their goal? So there's kind of two ways that I want to jump in a little bit more detail here on the ideas of how do we sense physical state, and then how do we infer, after this set of slides, how do we infer the behaviors one might be performing which could then inform whatever our intervention is, right? And so you can kind of see that, control loop of sense physical state, sense behavioral states, which in and of itself is a fairly challenging problem mixed in with a little bit of machine learning, a little bit of interpretation, and then have that agent in the loop that hopefully connects and works with the human on the other side, the patient, to then make some type of decision on care. So how do we sense the physical state? So this is part of the DARPA and also now ARPA-H Thor project. So wearable, configurable platform that can put around the body that can get different markers, everything from, actually shown here, ECG, EKG, multi-wavelength PPG, different other heart rate variability factors. And in fact, that graph on your right shows all the data that we're gathering in one beat of the heart. And so this type of cardiography or cardio-related information can be really useful for all types of ways that we might target dosing, right? Because each of these different therapies have different constraints, have different side effects, have different requirements, and those are actually, each of them exist in their own, often separate fields of health, of medicine. And how do we account for all of those variables? Well, first we have to get some of the data that can help us make these decisions. So for this, we actually call it the Health Sensing Swiss Army Knife. This is actually almost a commercial product now, so if you're interested in this for other health studies, please reach out. It sits in an ecosystem around these living pharmacies that enables also experimentation with animals that we need to do to have validation and efficacy, as well as being used in the clinic for just straight sleep and circadian monitoring. And then that's associated with this mobile application that controls that ecosystem and makes kind of everything easier for us, especially as experimentalists, but also as the patient. So then the other side of this is how we sense behavior. And this is where maybe we're seeing, sense behavior to modulate that implantable therapy delivery. So, right, a behavior might be sleeping. Maybe the behavior is something like smoking. Maybe it's eating, but not just eating, it's binge eating. And maybe it's feasting or other things that have these kind of nuanced definitions of what an activity might be, right? It's more than just sleep. It's more than just walking. It's more than just, ingesting food. And that can potentially change how we might think about both the therapy delivery, but also other types of interventions that could exist alongside this. Because even if this implant is residing inside of you, it's one part of a treatment plan that has to be comprehensive, and it's going to include a lot of other things. So how do we use that data that's already there to inform those plans? All right, so challenges that we think of, especially in this space, are privacy, battery lifetime, and function. And so I think of this as that engineering trade-off triangle, where for anything that's wearable, anything that's an electronic device, you have to at some point make a decision on, well, am I going to gather lots of data so I can make a better informed kind of action or interpretation? But then I'm kind of sacrificing potentially the privacy of the individual, unless I have some other way to get around that. Even if I'm not sacrificing privacy, I might be sacrificing the energy efficiency because it takes a lot of energy to gather lots of data. And if I'm sacrificing energy efficiency, suddenly my device gets a lot bigger. And there were some versions of these implantable pharmacies that were the size of a credit card. And personally, that sounds really uncomfortable to have lodged in your abdomen. And so we have to make these decisions on where in this trade-off triangle we can sit. And this is a co-design problem across fields, across the intersection of fields. And it can't really be made in isolation of like, well, this is what the clinician said, or well, this is what the computer engineer said. There has to be a negotiation. And in some sense, some of these challenges are deeply invested. There's no good choice. So ways that we've tried to navigate this, I mentioned this face mask project. I just show that here as ways that we think about getting around this trade-off triangle is by tacking on interesting potential or interesting other directions. So this actually used energy harvesting from breath to lengthen the device lifetime so that we could bring that strict requirement for power and almost obviate it in a way, right? So now we only have to think about maybe function and privacy and the actual signal processing on device to infer things like your heart rate from the face mask, or provide recommendations on like, hey, replace the mask, it's broken. You've been wearing it for a week in ICU, maybe we should have known that way, but it's not doing its job. And of course, this was really cool because this brought to bear these ideas around the sustainability of these devices that are used maybe in the clinic, but also outside the clinic, and how adherence and burden are really going to change a person's interaction and use of a device. So we can't just ignore the patient's needs and environment and context. Another one of these is this idea around eating detection. And I show this just to help us all think about the varied ways that something as, maybe as, well, for those non-eating scientists in the room, something as simple, quote unquote, as eating is. When in reality, something that's so simple, but that we all rely on, is extraordinarily varied in the real world and in real life. So we've done eating studies for the past decade now, and we have videos of people, and they've consented to this, right? Wearing a wearable camera in a car. They're on their way to work in Chicago. One of their legs is up, kind of up on the steering wheel. They're putting on makeup. They're also eating, and then somehow they're driving. And we're like, where's the third hand, right? That doesn't make any sense. I think she was using the knee. Anyway, with Chicago drivers. But we also had things where like, okay, we're going to detect eating, so we're going to design the system where it just gets the proximity between my jaw and my neck, where my pendant is, right? Well, that works reasonably well, but there's two kind of major confounders there. One is if I have a BMI over, I think about 37, I don't have as much neckline to detect, and I will miss those events. So unfortunately, that means that the eating detection device, which may be deployed for an intervention for obesity, is not applicable to the actual population that it's being used in. So I show that as an example, right? Because there's other mistakes we can make in all of these other things that aren't considering like, oh, body type might impact how I would use a wearable or how I might deploy intervention. Another confounder is we had one participant who drank milkshakes the entire week that we deployed this, and they had 0 eating events detected because they would put something in their mouth, they would just slurp on the smoothie, and that was their entire liquid diet, right? So that wouldn't detect that for this type of device. And of course, there's many other devices. This is just kind of an example of these confounders that can happen in device design, but then they also influence the downstream data analysis, the inference, everything. Here's just kind of what that looked like in terms of determining these signals. And of course, there's tons of these systems now. This is just a review of these devices that in the past decade or so, often wearable generally, sometimes implantable, that are detecting different types of behaviors, right? These are actually looking at smoking and eating, right? Because that was a focus. Oh, sorry. So I'll wrap up with kind of just a quick preview of some of the things around privacy. I, again, talk about privacy and confounders as just one aspect of these challenges in this living pharmacy, this implantable pharmacy ecosystem. You can think of visual tools, like I said, that sit and watch you sip or chug or eat. These often have a lot of potentially damning information, right? So maybe you're picking up drug use, maybe you're picking up partners doing things, like a lot of things that are very sensitive. So how can we design cameras and also inference and intelligent approaches to preserve privacy, but also have some level of clinical utility, right? Can I remove pixels that aren't important to what I want to do? And we've spent a long time working on this problem of activity-oriented partial obfuscation, where we remove those pixels that maybe are not necessary, to then use that for different types of inference. This was through thermal utility, right? So we'd have thermal cameras on top of the regular camera that you would wear around your neck. And then tools that would make this labeling and this exploration a little bit easier to do. And highlight out to Nabil Ashrafa at Feinberg School of Medicine at Northwestern for doing a lot of most of this work and also building this data infrastructure for others like ourselves to build on top of. All right, so privacy, battery lifetime, complexity. Battery lifetime limits what we can do. Privacy comes up again and again because it's very personal devices. And the complexity of inference because of these multimodal data sets. Back to this implantable pharmacy, right? We're seeing how within this space, there's all these different places for data, for intelligence. So what does that mean for these opportunities and risks as this, I'm going to call it a new ecosystem of technology. People have talked about it for a long time. As this new kind of cyber capability comes to bear. So all the pieces are coming together. Now what? Well, and I think the big focus for the next 5, 10, maybe 20, but that sounds too long, years, really hopefully a much shorter time horizon, is to think about how to distill and embed things like this clinical side data that we know of a patient in this device to help guide decision making. How do we do more interesting sensing and understanding of a person's state? Does this include even hosting cancer digital twin or a personal digital twin on device to help assist with those types of actions, which is kind of where we're in the nascent stages of? What other activities and behaviors might inform this? And then also what types of things or agents might be interactive so that a patient has, or at least feels like they have, more control of what's happening inside their body to this treatment that they've consented to, but also maybe they are not completely and fully aware. So all of this kind of encompasses everything from health communications to patient interaction to device design to intelligent tools. And I think we have a lot of room to, I say play, because we are researchers and we're scientists and we're engineers, it is fun, but also really carefully consider the positive and negative outcomes of how we would implement these technologies. So this is most recently, and maybe most excitingly, in the past about 6 months, we've turned this project into a ARPA-H-funded Thor project that's led by Omid here at Rice. The idea is to target ovarian cancer. We've been going at it for about 6 months, and actually we got approval to, fingers crossed, get a clinical trial going within the next 2 years to deploy some of these devices. So this is really happening, and these devices will exist. So how will we react and think about them and use them in society and integrate them with what we as data scientists, as practitioners of artificial intelligence, as machine learning and statistics experts apply these things? So these are very exciting devices, maybe terrifying challenges, maybe a golden opportunity. Success is really going to require what we have here, really interdisciplinary, patient-centered approach and process on integrating these results. And I think we can all just gather together and think about how this merger or this collision of AI and ML techniques and systems, device builders, with bioelectronics, cell therapies, and this whole device ecosystem can really create a more equitable, responsible, sustainable, accessible, and personalized view and vision of health. And I'm really excited about it. I welcome any questions. Thank you all so much for your attention.